Ladies and gentlemen, I want to thank everybody for being with us today on a Sunday. It's really nice to have you all with us. Thank you for joining this webinar on thyroid radiofrequency ablation. We're very proud to have Dr. Morley present our webinar. Dr. Morley is a consultant head and neck radiologist from the United Kingdom, the first clinic to start radiofrequency ablation in the United Kingdom. So we're very, very happy to have him with us today. It's actually the second thyroid webinar we're holding because of a high demand, and this time we're holding it on a Sunday AM hours in Europe to try and accommodate more people who are east of us, where it's later in the day. So thank you, Dr. Morley, for being with us today, and I want to thank everybody for joining our webinar today. It's really nice to see such an attendance on a Sunday.
Great. Well, thank you very much for inviting me to do today's thyroid radiofrequency ablation webinar. I'm just going to share my screen with you so we can show you the presentation. Is that all okay? Can everyone see that?
Yes, that looks good.
Okay, so I'm Simon Morley and I'm a head and neck radiologist at University College in London. So I'm not an interventional radiologist as such. My specialist area of interest is things like thyroid, and it's through this that I've done a lot of procedures, a lot of FNAs and biopsies, and that's how we've got into offering thyroid radiofrequency ablation as a treatment. This is the hospital where I work. We're quite lucky. They've just built us a brand new hospital, and it's really nice to have these new facilities in the UK to work in. So the first thing I'm going to do really is talk through the indications for ablation. How do you select which patients you're going to treat? So really there's two big indications that we're looking at. This is the main one. So a patient comes in, they've got a big symptomatic nodule in their thyroid. It's causing an obvious visible swelling. They don't like the cosmetic elements of it, and it may be causing symptoms through pressure, and it may be causing tracheal deviation. So assuming that this turns out to be a benign nodule when you ultrasound it and take your FNA, these are the sort of patients who may be suitable for radiofrequency ablation as an alternative option to having surgery or doing nothing and living with the symptoms and the swelling. The other group of patients who we can potentially treat with radiofrequency ablation are patients who have a nodule, not necessarily one that's visible or symptomatic in terms of the size of it, but one which is toxic. And these patients who've got essentially hyperthyroidism, sometimes they've got just a suppressed TSH, but essentially they've got an autonomous functioning thyroid nodule. And we've got quite a good evidence base that these patients can be treated effectively with ablation. And this is much preferable for the patients compared to having surgery with hemithyroidectomy, maintaining carbimazole treatment, or having radioiodine treatment. So this is a kind of summary of the indications for the treatment. So we've got a visible cosmetic swelling. People say that you should be treating nodules with RFA if they're bigger than 2 centimeters. I think that we have to accept that there will be some patients who've got isthmic nodules, which will be quite cosmetic and are causing them a visible swelling in their neck, where the nodule may be less than 2 centimeters, and they may be entirely suitable for the treatment. Ideally, we would treat patients with a solitary nodule. These tend to be a bit easier to treat with radiofrequency ablation, but if someone's got multiple nodules in one side, you can treat them, particularly if they're all clustered together. If patients have really got a very extensive multinodular goiter, it becomes more challenging to treat them because you're essentially ablating a large volume of thyroid tissue. The symptoms that we are trying to improve are things like pressure, tightness, and difficulty in swallowing. And of course, these are quite subjective symptoms. And it's always quite interesting that some patients come into the hospital or the clinic and they've got very small nodules and they say they've got dramatic symptoms. And then we have other patients who've got huge nodules and they seem to have very minimal symptoms. So the symptoms are much more soft things as compared to visibility of swelling and being able to feel swelling in the neck as well. And then, as I said, autonomous functioning nodules. The workup for these, we like to have a technetium scan localizing the nodule to that side where you can see the nodule on ultrasound. these are much better if we've got a solitary nodule. Any of the patients where they've got multiple nodules, this is called plumber's syndrome. It's much more difficult to control their thyroid function because often the thyroid hormone production is from more than one nodule, and it's quite difficult to achieve a complete ablation. So really, for the autonomous nodules, you want a solitary nodule to ablate. Clearly abnormal thyroid function, and it's helpful to know that their antibodies are negative, because what we don't want to be doing is unnecessarily treating people with Graves' disease or masking other autoimmune thyroid disease. In terms of the contraindications, clearly any patients where they've got abnormal cytology, anything other than benign, are currently unsuitable for radiofrequency ablation. That may change down the line. We may be able to, in the future, treat people with follicular lesions and that sort of thing with ablation, but currently it's not within our guidance. I think we have to be quite careful treating low nodules, ones which are going retrosternally and retroclavicular. It's just much more challenging getting the access down there, and you start getting quite close to brachiocephalic trunk and things like that with the needle. It's just a bit more difficult. I think in theory, you could have a patient with nodules extending below the clavicle where you ablate the upper part of the nodule, and it may elevate the nodules behind the clavicle for a second treatment. But I think on the whole, these are quite challenging to get effective ablations on. Sometimes we see patients where nodules extend posterior to the esophagus, and clearly this is quite difficult and dangerous to treat. There's a risk of perforating the esophagus, and the recurrent laryngeal nerve will lie in this area. And I have had patients coming to me with absolutely enormous multinodular goiters wanting ablation, and I've said to them, look, I'm not sure it's going to work. They've had treatment, and really, when you've got a vast multinodular goiter, the ablation is not as effective as we'd like it to be. And so in these patients, I think surgery is probably the best option. As I've already highlighted to you, in these toxic nodules where we've got multiple functioning nodules, that makes it difficult. So if someone comes to me and they're hyperthyroid with thyroid nodules, and there's like 10 or 15 nodules in the thyroid, maybe small ones, much less likely to be able to help them with RFA than if there's a solitary nodule. This technique is performed under local anesthetic. We don't use any sedation. We like the patients to be awake, because if it's painful, they can communicate with us and tell us if it's uncomfortable. And that gives us a bit of a warning if we're near anything where we're producing heat, and it's just good to have the patients awake. The key really to delivering it effectively and the patients being cooperative is to have good local anesthesia. And what we do is we actually numb the skin with an incredibly small needle. You can get these needles, they're made by TSK, they're absolutely tiny, and we numb the skin with this. It's a very small needle. And then we go in with a standard orange needle down to the thyroid capsule. And then what we do is we use this long needle with this spinal needle. We take the stellate out of it, and the needle is then actually quite bendy. And what you're able to do is get your local anesthetic into the sort of subcapsular perithyroid tissues. And you can sort of bend the needle around to the edge of the lateral edge of the thyroid and encourage the local anesthetic to go around there. If you get the anesthetic really good around the thyroid capsule, and when you're delivering the treatments, the patients tend not to feel very much. There are one or two areas where it can be more challenging with the local anesthetic, particularly around nodules around the trachea, and also quite posterior nodules, because it's clearly difficult to numb the posterior thyroid capsule. When you are doing ablation on nodules posteriorly, the patients can get discomfort in their neck and things, and radiating up to the jaw and chest. So you just have to be a bit more wary when you're doing those, because it's more difficult to get the anesthetic there. A bit like with the ethanol ablation, we use a mix of about 5 to 10 mils of lidocaine and 5 mils of bupivacaine. We actually mix it in the syringe together and inject it around the thyroid capsule, the skin, and so on, as I've described. So in terms of the actual kit that you use for the setup, There are three parts really to the RFA kit itself. So clearly you've got your needle here. And the way that the needle works is that you can see the shiny silver bit at the end is the active part of the needle. That's going to be doing the heating. The black bit doesn't heat up. And the size of that is what's called the active tip. And the sort of average size that we use is 1 centimeter. And I'll come back onto that in a minute. What the needle actually has is it's got the ability to create heat, but it also has an internal cooling system with a water system which comes all the way down into the tip of the needle, and this prevents tissue charring on the needle while you're delivering the treatment. Then you also have a generator. This is the radiofrequency generator, and it looks complex, but it's actually very simple. You've got a number of things on here which tell you what you're doing. So the first thing is that you've got your power here. You can see the power is 45 watts. And then you've got the impedance of the tissue here, which is 80. And so you will be looking at these things while you're ablating, and these numbers will change as you're doing your ablation. So I'll come back to that later on in terms of how you watch those numbers and what they mean. We were using this ultrasound machine for delivering our treatments, and what we actually found is that you could turn the machine round and rest the generator on the ultrasound machine, and this allowed you to have both things in fairly clear sight, one above the other, and that allows you to not only see your needle position, but also allows you to monitor those things on the generator. So just very briefly on the technique, how do we actually deliver it? Well, we come through the thyroid isthmus with the needle, and I'll highlight in a minute why that's important. So we've numbed the skin here, we come through the thyroid isthmus, and what we do is we move the needle tip, let's say, into position 1. Now, position 1 might be at the inferior end of the thyroid, and then you would turn your generator on, knowing where you can see your needle tip, and you would ablate zone 1, the little sort of ball there. And then when that's ablated, you move your needle tip back to position 2, then to position 3, and then you would turn the generator off and you would reposition the needle at position 4, 5, 6, and 7. So there's quite a bit of stopping and starting as you reposition your needle, but the key thing is that you have to make sure that what you're delivering is safe and that you know that your needle tip is always within the thyroid tissue and you're confident on its needle position. This is sometimes more challenging than you'd imagine, because when you ablate the tissue vaporizes and you end up with the gas in the tissues. And of course, this creates echogenic changes around the needle tip, which make it at times quite challenging to visualize the needle tip, particularly when you're trying to get close to a previously ablated zone. So effectively, we just move carefully through the thyroid tissue, I tend to work from inferior to superior, going medial to lateral. And an average ablation may take about 15, 20 minutes. The patients can tolerate about 20 minutes of it. After that, they start getting a bit more fidgety, and also the tissues start getting a bit warm after that sort of time. Now, in terms of things that we're trying to avoid, clearly you can see that we've got the recurrent laryngeal nerve here. And so what we have is this sort of danger triangle. You'd be very wary about coming right close up to the medial thyroid capsule here, because you could produce some heat or inadvertently damage the recurrent laryngeal nerve. And similarly, we have the esophagus here, so mainly bulges to the left, and that would be a concern if you're ablating a left-sided nodule. So the reason we come with this transisthmic approach is that it's just substantially less easy to hit or damage the recurrent laryngeal nerve coming from medial to lateral. If you were coming from lateral to medial, you can imagine you could actually injure the nerve surprisingly more easily. Okay, so these are the sort of things, and I will talk about complications and consent later on, but the kind of things that you can get of bruising and voice changes through damaging the recurrent laryngeal nerve, and clearly esophageal injury. I will come back to esophageal injury, but just a quick word on it. The esophagus contains gas, which is bright, and it can look remarkably like bits of sort of ablated thyroid tissue, and particularly if you're ablating a large nodule, which goes posteriorly close to the esophagus. Once you're in the middle of the ablation, it can be quite difficult to delineate the two. So really the key skill associated with radiofrequency ablation is being able to visualize your needle tip confidently at all times on the ultrasound machine. If you can see your needle tip and you know where it is in the thyroid, then you're safe to ablate. But if you don't know where your needle tip is and it's difficult to find it, you really shouldn't be ablating. And in those circumstances, you can just withdraw the needle tip till you can see it and then reposition it carefully. So I think the message really with the safety and effective ablation and reducing complications is know where the needle tip is at all times. I say that, but when you are doing an ablation, you are pulling the needle back towards you. So there is an element where you find the most distal part where your needle tip is sitting and you start your ablation there. It's fairly safe to do your ablation coming back towards you at that point. So long as you don't, of course, start coming out of the thyroid capsule towards the skin as you're pulling it back towards you. But it's much safer as you're pulling the needle back towards you to be ablating, even if you're not exactly sure where it is. It's that moment when you start, which is the crucial point. So once we've delivered the ablation, we give the patient a cold compress over their neck, and I don't know whether that actually helps, but it makes the patients feel better and they feel very loved when we do that. We give them about a 30-minute recovery, a cup of tea, because this is England, and they get a biscuit, and we say, are you okay? Occasionally, if it looks a little bit swollen afterwards, I might rescan it, but generally I don't rescan. And then we just check the dressing it doesn't need changing, and we give them some simple analgesia with paracetamol and ibuprofen, and off they go home. So it really is a day case procedure that you can deliver effectively. We give them a phone call the next day just to make sure everything's okay, and then we give them contact details in case it becomes more red, painful or swollen after 48 hours. Some of the complications can develop a few weeks or months afterwards, and so it's worth just making sure that they have someone to contact if they have any problems. And we then follow them up currently at 1 month, 6 months and a year, but these are just completely arbitrary. I'm not sure the 1 month follow-up helps that much because there's still quite a bit of shrinkage to occur after that. So it would be reasonable to just follow them up at 6 months. So what kind of results can you get with RFA on thyroid nodules? So here's a benign, partly cystic thyroid nodule with some dense colloid in the center. And this is 3.4 by 2.8 and I think 5.1 centimeters. So we treat this with RFA and this is what you get. It substantially shrinks down. So now we're, I think, 2.6 by 2 by 3 centimeters. And what you can see, if you look back, this is causing quite a big bulge on the anterior thyroid capsule. And now the thyroid is much more normal in its contour. And the patient may not really be able to feel this nodule. So you've gone from this to this. And if you plug these dimensions into this thyroid nodule volume calculator, we can see that the initial nodule was 5.1 by 3.5 by 2.9. That was 26 cubic centimeters, which is quite a decent sized nodule. And it's now 3.1 by 2.5 by 2.2. This is an 8 cubic centimeter nodule. So it's almost 70% volume reduction. And for a nodule of that size and that solidity, that's a pretty decent volume reduction. And the patient was extremely happy. She didn't want to have surgery. Her symptoms reduced. The visible swelling is now gone in her neck. So what's the evidence base for radiofrequency ablation? Well, as I said, it's a very, it's the most assessed and studied, and it's got the biggest evidence base of all of these non-surgical treatments. And really, I would refer you to the 2017 Thyroid Radiofrequency Ablation Guidelines, which are written by the Korean Society of Thyroid Radiology. And these are really fantastic. And this article summarizes beautifully all of the data. And it covers the indication and workup, nodule composition, efficacy, number of treatments, and safety. So if you want one reference to look at, this is the one. It summarizes all of the relevant data for you. Very briefly, for solid nodules, there are 21 studies looking at the treatment covering 1,503 patients, and they looked at both cosmetic scores, symptom scores, and volume reduction. And you can see that the volume went from approximately 12 to nearly 3 cubic centimeters, which is a mean volume reduction of 80% overall. But solid nodules, so this is 80% for all nodules, but for solid nodules, 71%. So that's one of the factors which is going to determine how effective your ablation is. Solid nodules tend to respond a bit less well than cystic nodules, and you can imagine that the cystic spaces may collapse a bit more once you do your ablation. And you can see the cosmetic and symptom scores improve as well. This is a busy thing taken from the paper, but you can see here down the very right side of the screen, volume reduction rate, 73%, 84%, 82%, 87%, and so on. You can see they vary from the 60s up to the 90s. And really, you can also see that the average size of the nodules at baseline is around 10 cubic centimeters. And this is important. There are some here where the nodules are larger, 24 cubic centimeters, and we'll come back to that in a minute. Okay, here's another paper just highlighting the efficacy. And the reason I'm flagging this paper to you is that the follow-up in this is a bit longer. Most people have been following patients up for 6 months or a year, but in this paper, they followed people up for up to 60 months. And I suppose what was interesting to me was to see that nodules were shrinking, 84% at 2 years, 89% at 3 years. In other words, nodules would carry on shrinking over a number of years after the treatment. So initially we were saying to people that you'll get your maximum benefit at, let's say, 6 months to a year, but it's probably shrinks more than that over the subsequent years. So cystic nodules I've already highlighted to you. There's a pretty equivalent thing between ethanol and radiofrequency ablation. And you can see in this summary table the difference between RFA on cystic nodules and solid nodules. So cystic nodules, look at this, fantastic, 90% reduction. Solid nodules, okay, 70%, 50%, and in this paper, 90%. So solid nodules, that's the message, do respond less effectively than nodules which have some cystic change. So how many treatments do we need to use? Well, really, some of the larger nodules may need to have a second treatment, and with several studies with a follow-up of more than 3 years, 2 or more than two sessions of RFA were necessary in about 25 to 50%. I would say that about a third of patients, and particularly these are the ones with the nodules bigger than 20 centimeters, may need to have a second treatment, and we consent them for that at the time of their treatment. When do they have that done? At around 8 to 9 months, you can see that the volume reduction is not as much as you want. Okay, so this is an important thing, and we use this information when we consent patients, which is that what determines the outcome? How do we know how effective this is going to be? And I think 20 cubic centimeters is quite an interesting cutoff. Bigger than 20 cubic centimeters, these ones proportionally respond a bit less, and I would classify that as a big nodule. If you've got a 40 cubic centimeter nodule, that's clearly a very big nodule. The cystic ones respond more than the solid ones. And then the other factors are how much energy was applied to the nodule. So at the end of the treatment, you can monitor your energy and how much you've given, and how complete was the ablation. You know, did you actually manage to ablate most of the thyroid tissue? Clearly, you don't want to go absolutely wild with it and ablate every single tiny bit. You've got to do this safely, and you've got to do it within a reasonable time span. But these are the factors that are going to determine how effective it is. Just a quick note on the evidence base for the autonomous functioning thyroid nodules. We've actually had pretty good success with this. So we've treated 13 patients with autonomous functioning thyroid nodules, and in 12 of those, we've got euthyroid patients at the end of it. Now, we have been quite careful in our selection of these, and these are patients with solitary autonomous functioning nodules, not patients with multiple nodules. In this paper from Korea, they improved the hyperthyroidism in all patients. They got an 81% volume reduction, and they got 80% normalization of TSH rate. And basically the larger nodules, usually than 20 cubic centimeters, they found that the patients maybe didn't respond so well or needed a second treatment. This was a patient who came to me with a raised T4 and a suppressed TSH and a solitary nodule, which was benign on cytology. And you can see it there. And we did the RFA, and this is what it ended up looking like. And the thyroid function is now back to normal. 76% volume reduction and a happy patient. Okay, so once we're in, I'm going to head to the most inferior and medial part of the nodule. Now, I'm not going wild with this nodule. It's enormous. I've got so much tissue to ablate. I don't need to go crazy with it. So here's the lowest part of the nodule. There's my needle tip. I can confidently see where the needle tip is. And I'm very quickly just going to start ablating. And what you'll see is the power will come on, and then we'll quickly turn it up to maybe 50, 60, and then you can watch the impedance. You'll see around the needle tip all the gas forming as it starts ablating. Okay, so here we go. Power's on. You can see 30. It always starts on 30, and look, I've told them zing it up, put it on 50. And then within a few seconds, you can see little bits of gas occurring. And I've got a bit bored because it's not happening fast enough for me. And I've said, bung it up to 70. And then very quickly, you can see it popping. You can see the gas forming. And you can see that this is ablating fairly quickly. Now, as I said, I'm not going, I've only got 15, 20 minutes to do this lady's nodule. It's pretty massive. So I'm going to go fairly quickly through here. So sort of ablated a bit there, and then I'll start moving the needle around. This is what ablated tissue looks like after you've been through it. You've just got loads of gas in it. You can see we've got no perithyroid hematoma. And at the end of it, we just take our needle out and got a little hole there and just push on it for a few minutes. She's a bit more swollen than she was, but there you go. She's got 2 small little holes, put a couple of plasters on, cup of tea, and she'll be going home in about half an hour. So here's another study where overall the complication rate was 2.1%. But the major complication rate was 1.2%, and major being nerve injuries such as recurrent laryngeal nerve, sympathetic ganglion damage, brachial plexus damage, spinal accessory nerve damage. I would say that these complications, these nerve injuries, are really because people are ablating when they don't know where their needle tip is. That is the key to avoiding that. And then other things, and these are more difficult to avoid, nodule rupture and hypothyroidism, as I said, is very rare. Minor things, I've had one patient who's had a hematoma at the beginning of the procedure, a perithyroid hematoma just when we put the needle in. It just dissipated in the neck. It wasn't a big problem. We just carried on. And people, sometimes people will vomit. This is some of the feedback that we've had from RFA. Here we are. This is where I do the treatment at University College Hospital. The team were fantastic. The procedure was not the terrifying experience I was expecting. I was scared up to the point where the first ablation happened, and then I instantly relaxed because it wasn't painful. There was very little pain in my case. I could feel at times the probe moving in my nodule, some jaw pressure, and the popping of tissue under the probe's heat, I suppose. But even if it sounds weird, I actually liked the sensation, like bubble wrap was being popped next to my skin. So this is the kind of experience that patients will have. Some patients do experience more pain than others. I have to say the young men tend to be a bit worse in that regard than the women. And really, if it's painful, we just reduce the power for a bit. We give them a few minutes, we stop, and at times we just give them some more local anesthetic. Potential future developments for RFA. I think this is potentially the big one, treating thyroid microcarcinoma. And there are some papers coming out which are showing that this is potentially effective. I think the difficulty with these papers is that many of these papillary microcarcinomas are not that clinically significant. And as we know from the Ito paper from Japan, these low-risk papillary microcarcinomas, if you do surveillance on them, many of them will do nothing over a substantially long period. But this is something that patients find very difficult to cope with. They don't like to be having a cancer and not having any surgical treatment and just being on monitoring. So ablation potentially offers a halfway house. And I suspect that in the next few years, this will become an option as an alternative to active surveillance.